pioneers, instrumental for the National Diabetes and Prevention Care Plan in Israel. And Professor Raz is currently the president of DCure, which is a non-profit for cure and better treatments in diabetes. He was a past president of the Israel Diabetes Associations. He is virtually there on every diabetes journals, But world famous he is because he has had several publications from CODI, which is Controversies to Consensus on Obesity, Diabetes, Hypertension, and that has left a footprint for the last 2 decades all over the world. And he has been a very excellent speaker, teacher par excellence, educationist, researcher, and a clinician. Professor Itamar Raj.
Thank you very much. Great pleasure to join you today. I would prefer much better to be in India, since this is the country that I really love. I love the country, I love the people. I want also to thank Professor Sabo for inviting me and for the great meeting. And maybe the advantage about being away is that I can show you where I am. You can see here the beautiful view of Israel, of the shore of Israel. I hope you saw it. And actually, when I heard Juliana Shan and Professor Misra, I asked myself why in Israel we also had relatively few deaths from the COVID, actually less than 1.5%. Is it because we have good medicine, or is it because we are lucky like India, or maybe both, or maybe India have very good medicine? So today I want to go over together with you about thinking about the COVID and about what does it mean today and what does it mean for the future of therapy in diabetic patients. And this is coming from the forum, the CODI Expert Forum, which contains several well-known
Professor Raz, are you there?
I think his connection is
field of diabetes. Juliana Chan is one of them, and
he is breaking it in between. I think we have lost him again because the video paused.
Oh, now I can hear you. So let's see if we can. So actually,
Dr. Itamar, can you just keep your video off? Talk, so that will be better. Just share your slides and keep your video off.
Okay.
Probably we will able to listen you better.
We can send you the video later. We can send you your video maybe in the next 2 hours.
Okay. The problem is that I cannot pass the slides. I don't know why. 1 minute, maybe. 1 minute. So you know what I suggest? Go to the next speaker, and I'll try to arrange my speech.
Perfect. Thank you so much, sir. We will try to reorganize it. Sorry about these technical glitches. We have Dr. Sabyasachi Sen.
No problem.
Dr. Sen, are you ready with your slides?
Yeah, but I'm not sure how to load them. Hold on.
You have to share screen. Dharmendra, can you just put up Dr. Sen's? So we are now moving to United States, and my good friend Partha, sorry I have to park you a little bit at the back. I hope you don't mind, Partha. And can we have Dharmendra? Can you just get Dr. help out Dr. Sabyasachi Sen?
Yes.
I will just read out. Dr. Sabyasachi, just help. You will have to just share your screen.
Okay.
So,
Sir, I can give my talk now. I think if you hear me well and you see me well.
sure, you go ahead, sir. Then. Dr. Raj, you can go ahead.
Yes.
Okay, thank you very much. So, the COVID-19 actually caught us with our pants down. It spread very quickly all over the world, and before we can react properly to it, actually, it was all over the world. And the question is,
Hi.
do you hear me?
You can show me your laptop so I have slides.
Okay.
Can you mute everybody so we can hear Professor Raj, and somebody can help Dr. Sabyasachi Sen for the next talk and talk to Partha also, Bansi. Go ahead, Professor Raj. Please go ahead.
Thank you. Thank you. So a lot of data came down by the last several months regarding the pathophysiology of the disease. I will not go into it, but we know that this disease actually affects several very important organs like the lung, the heart, the kidneys, the
क्या
liver,
करना है उसको लाइव मतलब यूट्यूब करना है ना
and the
यूट्यूब
brain.
लाइव करके आपको आईफ्रेम
And the brain. And actually, there are two main pathophysiologies for that. It seems to be that it affects tremendously the vascular and also the macrovascular vessels. And with that, it not only causes vasculitis, it also causes an increase in coagulation and an increase in the risk for strong coagulation in the small and the large vessel. Unrelated to it, there's also a very strong effect on inflammation within 7 to 8 days, and we don't know always who will develop cytokine storm and who wouldn't, but the cytokine storm actually causes inflammation in different organs. The most important seems to be the lung and the heart with myocarditis, causing heart failure and increase and vasculitis and increases the risk for death. Now, the predictors of severe disease and mortality are age, obesity, diabetes and hypertension, chronic lung disease, and cardiovascular disease. And we learned that actually years ago with the SARS outcome. In one study that compared 135 dying versus 3085 survivors of the SARS, the mean blood glucose level in those before they received steroid was 9.7 versus 6.5. And this made a very big difference. So a known history of diabetes had significantly higher disease patient than survivor. And we are talking about 21% versus 3.9%. Fasting glucose independently was associated with mortality and hypoxia also at that time with the SARS. And the other thing that was demonstrated then and are demonstrated again now is the relationship to stress hyperglycemia. So patients who were not known to have diabetes but developed stress hyperglycemia were at much higher risk for the disease, for development of severe disease, and for being hospitalized in ICU and mortality. And this is what we see many times with patients who are not known to be diabetic and who develop hyperglycemia in the hospital. Again and again, we show that those patients are at higher risk than known diabetic patients. So diabetes increases morbidity and increases mortality, and many studies have come. This is one of them from the United States, looking at overall 7,162 patients, demonstrating that the risk to develop COVID is similar between diabetic and non-diabetic patients. However, if you look at hospitalization rate, this is 2.5 more for the diabetic patient. And if you see how many were hospitalized at ICU, this is 3 times more, showing that diabetic patients are at a much larger risk for bad disease and for mortality. Now, very interestingly, recently, again from observational study, it seems that we learn a lot about relationship with the treatment to the outcome. There is a very new study now on metformin, and you can also see in this small study that patients who were taking metformin before the disease had better prognosis, although this was not significant because the number of patients was very small. And this was in spite of the fact that there was not a big difference in A1C between the groups. So in hospital deaths was much smaller, 4 versus 15, again, not significant because of the number. If we look at insulin, another important thing actually is the effect on biomarker, and you can see that those who were treated with metformin had much lower increase in biomarker than those who were not treated with metformin. Again, suggested that a cytokine storm might be easier if you are under metformin study. And just to remind you that some of the preliminary guidelines and suggestions were to consider stop metformin therapy in patients who develop COVID-19. Now, if we look at insulin therapy, the patients who are treated with insulin are at much higher risk for in hospital deaths, much higher risk for poor prognosis, which is now significant in spite of the relatively small number. And also their A1C is higher than those who are not taking insulin, not to mention all the biomarkers where CRP, IL-6 were much higher in those taking insulin. So is it a matter of how well controlled you are with insulin? Is it a matter of the fact that you are under insulin? Or is it just a matter of how long your disease is and how many target organs are diseased because of the long-term diabetes? But in general, we can say that diabetic patients have a severe disease versus those who are not diabetic. And this is shown actually in any study. Many times it is significant, many times it is not. But in most of the cases, it is significant. And the hazard ratio of this meta-analysis is 2.75 versus the non-diabetic patient. And this might be because of the older age, because of the fact that diabetic patients are obese most of the time, because they have immune dysfunction, because they have increased procoagulate state, also because of hyperglycemia and other diabetic reasons, because of pre-existing macrovascular disease, existing nephropathy and pulmonary disease, and because of oxidative stress and glycemic variability, not to mention as hypertension and other cardiovascular risk factors, which are more often in diabetic patients, and Julian already talked about. So the question is, does prior glucose control matter? And in a very small study, it was demonstrated actually that diabetic patients are those who will mainly die, and that pre-diabetes with hemoglobin A1C, hemoglobin A1C of 6.4 will increase their risk, but will not increase it significantly. However, the question is also whether inpatient glucose control matter. And several studies have demonstrated that diabetes, patients who have diabetes or uncontrolled hyperglycemia before admission versus patients who do not have diabetes or uncontrolled hyperglycemia at admission have a very different prognosis. So if you have diabetes or you have increased blood glucose on admission, your risk to die is nearly 4 times more than your risk if you don't have either of the two. And also, if we look at time in hospitalization, this is better when you have diabetes or hyperglycemia when you are admitted to hospitalization. So stress hyperglycemia carries poorer prognosis compared to prior diabetes. This was not shown in the small study that I've just showed to you, but it is shown in other studies. And for example, in this study, we can see that patients who have mean A1C of 5.9 versus those who have mean A1C of 9.1 had a very big difference in their prognosis. That, such as people who had pre-diabetes had increased risk of death, which was 3 times more than those who already had diabetes. And surely they have a long stay in the hospital. So what we learn from this, that we still don't know. It is clear, it is very clear that diabetes is grave. It is very clear that pre-diabetes is grave, but it is not clear-cut whether pre-diabetes or new existent hyperglycemia is really carrying much greater risk than diabetes by itself. And this is very important for the future treatment of pre-diabetes if you want to prevent them from mortality when they are hospitalized. One thing is clear that, and this was shown in several studies, that inpatient glucose control might do a very big difference in the prognosis of the patient. So if you can control your patient well when he is hospitalized, his risk, his mortality risk goes down very much. And surprisingly, also for hypertension, there's a great question whether ACE or ARB could be great for the diabetic patient because they increase the chance for the virus to go inside to the cell and multiply there. One thing that was shown, and there is also a new publication now in the New England Journal of Medicine by Mancini et al. That shows that ACE or ARB do not increase the risk for morbidity and mortality in the diabetic patient. If anything, they're reducing it with a hazard ratio of 0.8 to 0.9. However, this was not significant, but this is a good drug, and it's very important that the patient, when he is admitted, will have a good blood pressure control. So do not stop this drug, and this was the recommendation of the different associations. So when we talk about treatment of hyperglycemia, we want to have glycemic control in our pre-COVID patient and in our COVID patient. And this is very important, mainly in patients who are at a very high risk, who carry cardiovascular risk factors, who already have established cardiovascular disease, and who are not well controlled with their blood pressure and lipids. So if patients are asymptomatic or at a great risk for developing for risk from the COVID, we should treat them at home. We can also with the hospital care. We should continue the usual therapy, but we should do our best to control them as good as possible in case they will develop COVID or if they already have a slight COVID. The issue is when to hospitalize this patient, because sometimes we don't know who will be the one who will have a cytokine storm 7 to 8 days after they develop the disease. In a symptomatic non-severe illness, we should have a hospital, we should have a usual therapy with caution, but we should add insulin in order to do our best to control our patient, and we should consider withholding SGLT2, although we don't have any proof that this will make a difference. In severe illness, we should put the patient directly to ICU care, treat him with multiple daily insulin or IV insulin to control his blood glucose level. Now, Juliana Chan and also Dr. Mirza have demonstrated to us the relationship between A1C and impact or lockdown of vulnerable population. And what you can see here in the blue, the 20 days at home will increase by a mean of 0.2 hemoglobin A1C. So one thing we have to think over in the future is how can we protect patients with staying at home. And Dr. Mishra gave us a lot of data about what happened in the Indian population that were stuck at home in relation to weight gain and outcome later on. So altogether, when we talk about patient with COVID, we should always remember that this patient might develop cytokine storm even if they are doing relatively well. The connection with the hospital should be very strong. Every sign that the disease goes from mild to moderate disease should send the patient to the hospital to be taken care of by the different doctors that should look for the different problems and possibilities that they might have. And last not least, it's very important to remember that these patients are at great risk to develop hypercoagulability, and we have to do our best in order to treat them at the very early stage, either at the beginning with aspirin, and if there is a great risk to develop moderate to severe COVID, we have to start and treat them with anticoagulant as soon as possible. Also, nutritional recommendation is very important. Although it's not evidence-based, we should consider to treat our patient with a nutrition that contains antioxidant, which is always healthy. So we should actually treat our patient, even in a general days, with a lot of what we call Mediterranean food, with a lot of green and red fruits, and with a lot of vegetables that will, and nuts and so on, that will prevent them from deterioration. We learned in the COVID that in some certain places in China, for example, and also in other countries, low vitamin D, low selenium, low zinc, low iron, low B12, and so on can be deleterious. There is no proof about it. There is a very big controversy between us in the group of the expert forum. But since we don't know that, we should do our best to see that our patient be treated with the right food to cover all these, including vitamin D, although this was not yet proven. So with that, I want to thank very much the CODI Expert Forum. You can see the people, Juliana Chant with us today, Dr. Di Fronzo, Stefano Del Prato, Pozzilli, Kim Jong Kim, Professor Banshi Sabo, Antonio Ceriello, Bernard Standel, Philip Holm, Luc Van Gaal, Zacharia Gungarden, and Dr. Avivit Chan, Dr. Ning, and me as well. And with that in mind, we're going to continue with this group to look over all the data that are accumulating in a weekly basis, so we can brainstorm between ourselves what is the meaning of the current COVID, our future therapy of diabetic patient and pre-diabetic patient. Thank you very much. With that, I will finish. And this is the hospital that I'm part of in Jerusalem, Hadassah Hospital. Thank you very much.
Thank you so much, Dr. Raj. That was a wonderful presentation. Unfortunately, your slides didn't connect, so probably you will have to send us a PDF to Bansi and he can show it to everybody. But I think you made some very valid points. That the first thing which you told us is that pre-diabetes and diabetes and its impact, the gravity of diabetes and the differential impact. You covered virtually everything from the treatment perspective, hypertension perspective, hypercoagulable states. So, Professor X, thanks a ton for being there. I would ask only one question which has come up to us from our viewers, that do you think any particular type of medication, anti-diabetic medication, might have a protective effect for COVID, and any anti-diabetic medication might be harmful for COVID? We all know it.
Yeah, this
Yeah,
is a
Dr.
very
Raj.
good question. And as I mentioned, recently it seems that metformin might have a protective effect against inflammation, of why metformin can protect. All the other drugs, I mean, SGLT2 are a little bit aware of the increased risk it might cause in relation to ketoacidosis. However, I think that I wouldn't stop SGLT2, and if patient is not properly controlled with his glucose, I would add to him insulin therapy at the time where he suffers from COVID, at least until he recovers from it. And this is 14 days, whether he is hospitalized or whether he is treated outside of the hospital, in order to control his blood glucose level. And adding insulin might prevent the risk from ketoacidosis in those patients.
Thank you.
Out of that, I don't see any deleterious effect of any to protect, to control blood glucose level, to control hypertension or lipids, and the aim should be to have them control the best we can at the time when you're exposed to COVID, not to mention at the time when you experience the COVID.
Thank you so much, sir. Thank you. Thank you. And we'll move to the next presentation. You are truly wonderful, and we will keep sharing experiences. Our next speaker actually was supposed to be our last speaker. He's originally from Calcutta. Then he's a true migrant